Okay, welcome back to the second session, and we would like to welcome you all to the second session of the Second Students Forum for Health Research 2022, which will be chaired and moderated by Dr. Aid Al-Shati, and I am the Associate Professor in Pediatric and Vice Dean for Academic Affairs. And Dr. Mishari, he is going to be with me today. Dr. Mishari Gahtani, he is medical interns, and we would like to thank the organizing committee who arranged such an event. Special thanks to the medical club and creativity at the College of Medicine. In this session, we will have 3 talks. Each one will be for 15 to 20 minutes, and the discussion will be the end of the session. And the first speaker is Dr. Taha Al-Qahtani. He is Assistant Professor, Department of Pharmacology and Toxicology at College of Pharmacy. He is a Vice Dean for Academic Affairs and Development at College of Pharmacy. He had Bachelor degree of Pharmacy from King Khalid University, Saudi Arabia, and Master degree in Pharmacology from MCPHS University, United States. And he had Doctor of Philosophy in Molecular Pharmacology, University of Liverpool, United Kingdom. He has many publications in journals with impact factors, actually, and he has outstanding activity research. And he will conduct a lecture about experimental study design. Dr. Taha, welcome again, and the mic is yours.
Thank you, Dr. Aid, for introducing me. I would like to thank College of Medicine for this invitation. It's my pleasure and honor to be here today. And as far as I know, this event has been entirely organized by the medical students. So this is such a great achievement, and we all actually proud of you. So my talk today is titled with Experimental Study Design. So as an investigator, you can actually classify the experimental studies into 2 main categories, either observational or interventional study. So what is the main difference between these 2 things? There is a pretty much significant difference between observational and interventional or experiment study. In fact, the observational study here, the scientist does not influence the response in any way. They basically keep looking and observe the data and eventually write down this data. Whereas in the interventional study, researchers deliberately applies treatment before observing any response. On the other side, in the observational study, we can actually measure an association or a correlation. However, in the interventional study, we can establish a causation. And the difference between correlation and causation is very important. In the correlation, usually we have 2 groups, and they look like to have an association. So if one group goes up, the other group will go up, and vice versa. However, if we have a causation, that means we are able to prove that one of these things can lead to other things. So now, what is the hierarchy of evidence? Hierarchy of evidence is a way to rank different types of studies in order to help us to work out which one is most useful and which one is least useful. It's often drawn up as a triangle where we have in the bottom the least useful type of evidence, and as we move to the top we start to see the most useful type of evidence. So in next few minutes, I'm going to describe each one of these level of evidence, but before we're getting there, I would like to share with you that the bottom half of this triangle considered to be unfiltered information, and the top half considered to be filtered information. So what does this mean? It means that in the filter information, this information has been critically appraised and has been critically reviewed by an expert within the field. But at the same time, that doesn't mean the unfiltered information is not helpful or useful. In fact, the unfiltered information considered to be plentiful, so we can easily get this information and start to moving forward from low evidence experiment or study to the next level, a high evidence experiment or study. So let's have a look to the first step in the hierarchy of evidence, which is ideas, opinions, and editorials. And this includes what you would read in a magazine or in a newspaper or even what you watch through TV interview. So this is basically a one person expressing our opinion. It can be from expert person, but unfortunately it can also come from an expert person at the same time. The advantages include we have something to start from. Of course, in order to build up our research, we need to get some novel idea. We get to have a hypothesis, and then we start to test this hypothesis. And from this step, we should start. We should have an idea and opinions, and then we can move forward. We describe new symptoms, right, or a treatment, or even diagnostic tool, and etc. It's inexpensive and quick at the same time. The disadvantages include, because this is only one person opinion, we cannot end up with a statistical significance. Also, this is a descriptive, so we describe a certain scenario, but we cannot link this scenario as a causality, right? And then it also can lead to false ideas. This is like an idea and opinions, it's easily digested by the public. So we have to apply extreme caution when we talk about science, because this can lead to fake news and false ideas. It's a weak of evidence, and that's why it comes at the bottom of the hierarchy. And basically, there is a potential ethical dilemmas about whether we should publish the ideas and opinions or not, because there is no scientific studies to back up this information. So next, there is always a break between ideas and opinion and the second step in the hierarchy. It can usually, like sometimes it come before even the ideas and opinions, which is animal and cell studies. So let's say we have an anti-cancer agent and would like to study the effectiveness of this agent. So we start in the lab by doing what we call either in vitro experiment. So we use primary, secondary cell line tissue, and then we move to the next level, which is in vivo experiment using animal. All right, the second step is case reports and series. And for those who are not familiar with the case report, basically it's when you write up about one patient experience in the hospital. So you would write how these patients present to your clinics, how you would treat them, how you diagnose them, and etc. And then if you write a multiple case report using different people, they sharing the same characteristic, and then you will end up with what we call a case series. Advantages include creating case definitions. We will start to see something new in the field, and this is, by the way, it's a very useful tool for educational purposes for medical students. It's inexpensive and quick at the same time. There is some dedicated journal just for the case report, as Journal of Medical Case Report in PMC. And if we all remember together, for example, the HIV has been discovered through case series. Different patients came to the clinics, and then the physicians start to write case series. Those patients get pneumonia, and then after time they figure out those patients have a serious immune system dysfunction, and then at the end it turns out those patients got HIV disease. Disadvantage include, again, we cannot have statistical significance in case series or report. It's descriptive, again. We can have some sort of association, but not causation. It also may be misleading because maybe some scientists, they start to read case report or case series. They start to do a lot of experiments in the lab to figure out this hypothesis, and maybe at the end they got the wrong answer. So it might be misleading sometimes. It's also a weak evidence because we cannot generalize a case report or a case series for the whole population. Next is what we call the cross-sectional studies. And the cross-sectional studies, usually we look at the prevalence of a disease in a certain population at one time. So, or even we can look at some population characteristic. So in the cross-sectional disease, it's like a snapshot of a targeted population, and then we start to collect data and end up with some sort of analysis. In the cross-sectional study, usually we measure the exposure and risk factors with the outcome at the same time. So we don't have to move forward and follow up with the patients or with the population, and also we don't have to go back and start to collect the data. There is a very simple example. Let's say if you want to study the association between the weight and depression, so you want to study the prevalence of obesity in the depressed population. So you start to make a questionnaire, and then you go to this target population, ask them some questions, start to collect the data, and then you end up with the analysis. Prevalence, ethically safe, right, because we don't have to intervene, we just ask questions. No loss to follow up. We're just gonna ask the people one time, so we don't have to follow up with those people. It's inexpensive and quick at the same times. The disadvantage is, again, we can have correlation, but no causation. Here we estimate the prevalence, not the incidence. We cannot figure out if those people who are depressed get an obese at the same times, or which one happened before the other. It's also recall bias because we totally depend on the patients or the population if they remember the answer or if they give the right answer. This is one example of our work with my colleagues in the College of Pharmacy, and what I want to mention here, it's very important to choose the topic if you would like to do some cross-sectional study. As you know, the breast cancer is one of the top malignancy in the Kingdom of Saudi Arabia. It accounts for about 28 to 29 of all cancer in women. So that's why we thought this is very interesting to choose this topic, and we would like to study and to assess the knowledge of breast cancer, the self-examination of breast, and the mammography in the female in ASIR region, in KSA. So we initially choose our target population, female in ASIR region, married over 18-year-olds, and then we have our questions. We choose different variables, and then we conduct this study over 4 or 5 to 6 months for around 1,000 women. The good news is that 90% of female in ASIR region, they are fully aware of the breast cancer self-examination and the disease itself, but actually the drawback is only few of them, they are follow the mammogram test throughout their life. Next is the case control study, and here, because the case control study and the cohort study, which is in the next slide, they are pretty similar with some fundamental differences. So I would like to explain these two kinds of study, the case control and cohort, as a comparison, okay? So in both study, we have a case and a control. The difference is that in the case control study, we start to divide our target population based on the disease status. However, in the cohort study, we actually divide the population based on the risk factor. Let's have an example to make everything easier for you. So if we want to start to study the association between the lung cancer and the smoking, so if we would like to do a case control study, we will divide the population based on the disease status. So we have a lung cancer patients and patients without lung cancer. And then we can follow up. Actually, we can go back as a retrospective study, okay, and then start to figure out if those patients exposed to smoking or not. So this is a case control study. For the cohort study, we will divide the population based on the risk factors. So we have one side with people who are smokers and the other side with people who doesn't smoke. And then we're going to follow up for, let's say, for 10 years as a prospective experiment, right? And then to see if those people can get lung cancer or not at the end. So this is the main difference between the case control study and the cohort study. One more important thing is, like usually in these two studies, we have to measure an outcome. And to measure the outcome, if we have a case control study, we measure something called odds ratio. However, in the cohort study, we measure something called relative risk. I'm not going to explain the equation, but it's an easy, and you can easily figure out if you go back and read about these two types of studies. So advantage, we require short time, suitable for rare and long latent. Why it's suitable for rare disease? Because basically when we start in case control, we have the disease itself, lung cancer, multiple sclerosis, and etc. So we try to find out people with this disease, and then we do our experiment. It's inexpensive, okay. The disadvantage, correlation, not causation. Only one outcome, right, is recall bias, selection bias, and confounders like age and different characteristics. It can make a difference between these two groups, and then we will end up with some result bias. This is cohort study. I've already mentioned and compared this to the previous slide. 5 minutes are left. Then is the RCT, randomized controlled trials, and here we have our targeted population. Then we randomly assign in two groups. We treat one group and the other group is a control. So here we start to get the interventional experiment, and then we look after those people for our final outcome. Okay, so at the top of the hierarchy of evidence, we have systematic review and meta-analysis. Systematic review in when you collect, okay, a plenty of RCT trials, and then you write like the final outcome of 150 or whatever RCT trials. And in the meta-analysis, when you are going to do some sort of analysis on those systematic review, and this comes at the top of this hierarchy evidence. بالتالي هو أكثر موثوقية systemic review and meta-analysis. Okay, just to give a brief explanation about this. So if you go back to the hierarchy of evidence, we have observational, that means we don't intervene. And then we have interventional because we treat one group, which is the randomized controlled trials. We have a descriptive, فقط وصفية, and then we have some analytics. Let's have a quick example about real-life RCT trials. This paper has been published in Lancet Oncology with an impact factor of 54 in 2019. The scientists were interested to study if quizartinib versus sulfate chemotherapy in relapsed refractory FLT3-ITD AML patients has give a better outcome. So basically, patient with AML, they can get relapse if they have this sort of mutation. So scientists would like to study if we give a targeted therapy, which is a quizartinib versus the sulfate chemotherapy, is going to give a different outcome. And from the title here, you can understand many things. If we see here the multi-center, That means this experiment has been conducted in more than one center. Randomized, we randomize people in two different group. Control, we have a case. Open label, that means all scientists, investigators, patients, they know actually if they receive treatment or placebo, and then it's a phase 3 trial. This is how usually, if someone would like to do RCT trials, then you should follow like a chart similar like this. You start with, let's say, 563 patients, and then you have some inclusion and exclusion criteria, and then you will end up with two groups. One receive the drug of interest, and one group receive the placebo or the salvage chemotherapy. And then at the end, you have a graph like similar like this. So this is an overall survival graph. So in x-axis, we have the time, y-axis, we have the overall survival, and if you compare here, the blue line, we have the patients who receive quizartinib, and in the red line, we have the patients who receive the salvage chemotherapy. Let's have an example. After, let's say, 50% of patients who receive chemotherapy died after 6 months. But if you compare this to patients who receive quizartinib, we need around 8 months to get 50% died of patients. So that means the quizartinib gives some sort of beneficial in the acute myeloid leukemia patients. This is a primary endpoint, and then the secondary endpoint, it could be something else like event-free survival. So this is my talk. Thank you very much, and I wish you all the best in future, inshallah.
Thank you very much, Dr. Taha, for this informative talk. We will go to the next lectures in these sessions with Dr. Abdullah Sabani, who is Associated Professor and Consultant of Public Health, Department of Family and Community Medicine, College of Medicine, King Khalid University. And he is also co-CEO of for Assistant Medical Service, Medical City, KKU. Dr. Abdullah, Directors of Health Research Consultancy Office, Institute of Research and Consulting Studies at KKU. He is also Director of Saudi Boards of Preventive Medicines, Asir Residency Programs, Saudi Commissions for Health Specialties. Dr. Abdullah had his master's degree in public health from Dundee University, United Kingdom, and he had also his PhD in public health from the Dundee University, United Kingdom as well. He has many publications in public health and preventive medicines. He will speak today about observational study design. Dr. Abdullah, we are so glad to have you with us today. Mic is yours.
Thank you very much. Can I have the slides, please? Okay, inshallah, we'll try to cover the observational study designs in this talk. As you know, the studies is divided mainly into two types of design in general: the experimental and the observational study design. Dr. Taha has quickly came across the observational study designs, and I will just explain each one of them in details, inshallah. So why we classify, or how we classify study design? Actually, study design is different and can be classified differently according to our perspective and our scope of classifications. So we can first classify them as observational and experimental. Observationals, if we are only just observe, we don't have any interventions to implement. Experimental, if we have a specific intervention, if we have a specific drug and we give it to a specific group of people or group of patients and we administer this drug, okay, then this is an intervention. But if we sit back and we have no intervention, just we are looking at those who are smoking and those who are not smoking, and we are following them for a while, then we are just observing what's going to happen. So this is observational. The other ways of describing or classifying studies is descriptive and analytic. Descriptive if we are just only describing what's going on, and analytic if we are looking to different reasons, correlations and associations and comparison in general. Also, we can classify studies into comparative and non-comparative. Comparative where we are comparing 2 groups or 3 groups or 4 groups with each other. Non-comparative, only one group. We are describing only one group without any comparison. Also, we can classify studies into prospective and retrospective. Prospectives, if we started from now and looking to the future to see what's going to happen in the future. We give them the drug and we look to the future. Are they going to get treated or not? So this is prospective, looking to the future. Retrospective, when you look back, started from now and try to look back what happened last year and the year before to see and to understand what has been happened before. Also, we can classify them into pragmatic and explanatory, okay, according to the study environment. Pragmatic, usually community-based studies, while explanatory, usually in a lab or in a controlled environment. Also, we can classify studies into hospital-based or population-based studies. Okay, so observational studies, they are non-experimental, just observational. Treatment as exposures occur in a non-controlled environment. We don't intervene. We don't measure, enforce someone to do something. No, it's just we ask people, okay, how many smokers we have? Go to this side. How many non-smokers? Go to the other side. And then we observe them for a few days or few months or few years to see what's going to happen. So here, if we look here, the observational design, we look if there is comparison or not. If there is no comparison, it's mainly probably will be a descriptive study. If there is a comparison, then we go to the analytic side of observational studies. And in the analytic sides, we look to the direction of exposure, okay? If we are going to examine the exposures and look if the outcome is going to happen or not, then this is a cohort study. If we are going to recruit those people with outcome and we will go back to in the past to see the exposure, then this is a case control study. If we just at the same time look to the exposures and outcome, then this is a cross-sectional study. Okay? Usually in research, we started with case reports, and after that we have different case reports, what we call it case series, and from these 2 designs, which is mainly descriptive, we build hypotheses, and then we try to test hypotheses by analytic studies, whether they are cross-sectional, case control, or cohort. And at the end, if we have some testing here, then we'll try to confirm this testing by doing the experiment itself. So here is the case report, the weakest part, as we go up here, this is the strongest evidence, as Dr. Taha mentioned before. So case report, then case series, cross-sectionals, case control, cohort, and then randomized controlled trials. So the basic questions that we should ask in analytic studies, we always looking to a specific exposures and whether this exposure lead to a specific disease, okay? And we look if there is a link between a specific exposure and a specific disease, okay? And we can start either with exposure and look forward to see if the disease is going to happen or not, or the opposite, or we can pick up all those cases with the disease and looking back to see if they have been exposed to a specific factor or not. So the 2x2 table is very important, and it's explaining and summarizing the count of disease and exposure and how we recruit these 4 cells, the population of these 4 cells. This is will explain us the study design we are going to use. Here is the exposure, whether it is available or not, and those among those who were exposed, how many they have the outcome and how many they don't have the outcome or they don't have the disease. It's very important for any observational studies or even experimental studies to understand this table and to analyze it. Okay. Let us start with the first observational design, which is case report. Case report, as we mentioned, it's a detailed presentation of a single case, okay, or one or two cases. Generally report a new unique findings, and these unique findings can be a previous undescribed disease, unexpected link between disease and exposure, unexpected new therapeutic effects, or adverse events that rarely happen. All of these can be written in a case report. Then we move to the next design, which is case series. Case series, it's a group of cases, experience of a group of patients with similar diagnosis, and we'll try to describe all of these different cases, assess a prevalent disease. The case may be identified from many hospitals, from primary health care and hospitals, from single or multiple sources, but we try to understand a specific disease, a new disease. We would like to understand it more, so we try to pick all the cases around the kingdom about a specific disease to describe it and understand the disease. It's generally report on a new, unique conditions, maybe only realistic design for rare disorders, because rare disorders you don't have lots of cases, so you try to become from different centers and you try to describe these cases to be more clear for your colleague to understand this disease. Case series, what's the advantages of case series? It's useful for hypothesis generation, informative for very rare diseases with few established risk factors, and it's characterized averages for disorders. Disadvantages is cannot study cause and effect relationship because you are just describing cases, and cannot assess disease frequency because you are picking up those cases from different hospitals. The third design is the cross-sectional studies. Cross-sectional studies, we start from a specific point in time, and we have a cross-sectional sample from the population, and we try to describe this cross-sectional sample, okay? It's very important to differentiate between case series and cross-sectional studies. Actually, almost 75 of cross-sectional study in the literature, 75% are not cross-section. It's actually a case series. So we should understand the difference between the two. Here is the cross-sectional study. We started here, and we try to classify people into those with the disease, those without the disease, if we would like to make it comparative cross-sectionals and analytic cross-sectionals, and we look for those who have a specific factor and those who have not these factors among those disease and not disease. At the same time, we classify them into these categories, and we try to analyze the data about them. But it's all in one point in time. We don't know which one started first, whether the disease or the exposures. Cross-sectional studies is often used to study conditions that are relatively frequent with long duration of expression. Because if it is, let us say, severe fatal disease, you will not be able to pick up these cases and involve them in a cross-sectional sample because they already died. 1 day or 2 days and the patient is died. So you will not have time to include it in your cross-sectional sample. So usually cross-sectional studies is preferable to use with the long duration diseases. It measures prevalence, not incidence, and one of the examples is the community surveys. At the same time, it's not suitable for studying rare or highly fatal diseases or diseases with short duration because it's difficult to get a sample from those group of patients. Disadvantages, it's the weakest observational design, okay? Measure prevalence but not incidence. And the problem is with the temporal sequence of exposures and effect, you already don't know whether the exposure was coming before the disease or the disease before the exposure. it's difficult to decide about this. And this is one of the disadvantages of this design. Usually do not know when disease occurred, okay? And rare event is a problem, and we can't study rare diseases in a cross-sectional sample or a cross-sectional design. Also, quickly emerging diseases is a problem as well, and we can't study those diseases in this design. The other design is a case control study, okay? And in a case control study, we started here in our current time, and we try to look back in the history, okay? So started here, having cases and control, having cases, those with the disease and control, and try to look back if they have been exposed to a specific causes of disease or not. And then we can take the cases and take controls and look to the back history to see where the groups were having exposed to a specific factor or not. For case control, it's less expensive and less time consuming, easy to do. Just take the cases from the hospitals, and you can, from the same hospitals or from the community, from the same populations, taking a control group and compare between them, okay? Revise the history of both groups and try to compare between them. It is efficient for studying rare diseases. Why it is efficient for rare diseases? Because you started by picking up the disease itself. You will try to find all the cases with the disease from all over the kingdom, for example, because it's a rare disease, and you put them in one group, and then you can take control, okay? So it's good for rare diseases, easy to carry, quick and cheap, useful in early stages, okay, and allow for a study of several risk factors, because you take the case and you can look to different risk factors in the history back, not just only one risk factor, but you can assess many risk factors if they were present in the past or not. Useful in studying a disease with a long latency and doesn't require large samples and can prove some hypotheses and can estimate also the risk of odds ratios. Limitation of the design inappropriate when disease outcome for a specific exposure is not known. Exposure measurement taken after disease occurrence, which is also a limitation. That's why randomized control trial is the best, okay, and cohort study is better than case control, and we will come to explain it. Disease status can influence the selection of subjects, okay? For example, those with aggressive disease, apparent disease, you will include them as a cases. But those with subclinical, less aggressive disease, you will miss them and you will think that they are not a cases. So you are just consider the disease an aggressive disease, which is sometimes is not. Cannot calculate rates in this design. We calculate just odds ratio and not useful for rare exposures. Why it's not useful for rare exposure? Because when you take cases and you will try to see in the history back for the exposures, you will not find that they have been exposed to this because it's a rare exposure itself. Okay, so it's not good for rare exposures, and it's liable to different bias, whether it's selection bias or recall bias or information bias. The last design is a cohort studies where we started, usually we started from this time, okay, and look to the future. Look to the future. Try to go to the future. So we divided people into exposed and non-exposed, and then see which one of them will get the disease, okay? Looking to different risk or incidence of the disease over time. And it's the best observational design we have, and data usually collected prospectively and sometimes retrospectively. And we will just focus on the prospective part of cohort study. So we are in this here, current time, and we look forward. We take the sample, divided them into those who are exposed to a specific exposure and not exposed to a specific exposure. So here, look, we started in cohort with exposure. While in case control, we started with the disease, those who with the disease or not have the disease. So here we divided them into the exposure, and we look to the future who is going to develop the disease or the outcome in general and not to develop, and also here how many has developed the disease and how many haven't, okay, in the future. So it takes a long time. The strength of this design of cohort study is exposure status determined before disease detections. So we determine the exposed and non-exposed, and then we look forward to see who is going to have the disease. Subject selected before disease detections, which is give it a credit, also can study several outcomes. One exposure, and you can see for this exposures how many diseases is going to cause or to be a reason for. Suitable for studying rare exposure. So cohort is suitable for rare exposure. Case control is suitable for rare disease. So see the difference between both of them. Can assess the causal associations as well, and can measure incidence rate because we started by exposure, and we'll see how many is going to develop the disease. So we can calculate the incidence rate among the exposed and non-exposed. Limitation, it's expensive, time consuming, it takes time, inefficient for rare disease because you will recruit the people with exposures and you will wait 100 years and nobody has developed the disease because it's a rare disease. So it's not good for rare diseases. Loss of follow-up is also another problem. You recruit people and then you lost them. Thank you very much. يعطيكم العافية.
Thank you very much for comprehensive talk. Now we'll move to the third speaker, and it's my honor and my pleasure actually to introduce the senior consultant, my teacher, Professor Badr Al-Ghamidi. He's professor of in Department of Medicine and Internal Medicine, College of Medicine, King Khalid University, consultant of Chest, College of Medicine, King Khalid University, and Asir Central Hospital. He had American and Canadian board in internal medicine, and he had fellowship of the American College of Chest and American Board of Chest Diseases in November 1996. He is former director of Research Center of Health Colleges, King Khalid, for around 6 years, and he had been chairman of Medical Ethics Committee, College of Medicine, from 2016 to 2018. Professor Badr is well known, and he has many activities in research and community activity as well. We are proud of you, Professor Badr, and it is our pleasure again to introduce to this forum. Professor Badr will talk about the ethics in scientific research. And Dr. Badr, the mic is yours.
شكرا جزاك الله خير. بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سعادة الزملاء الكرام، أبنائي وبناتي الطلاب، في البداية أعتقد أنه لابد أن نهنئ أنفسنا أن ما شاء الله في يوم السبت ويوم من أيام الإجازات وإحنا في قاعة من القاعات نبحث ونتكلم عن البحوث، فإن شاء الله أننا نتطلع إلى علماء مستقبل إن شاء الله في هذه القاعة، وأملنا فيكم كبير جميعا أبنائي وبناتي إن شاء الله. والشكر موصول للزملاء جميعا والorganizing committee for inviting me to be here with you in this very important meeting. I'm going to speak about the ethics background in research. So I will try my best because it's only 20 minutes that I have to go through the basics of ethics in research. I have been the chairman of the ethical committee in the College of Medicine, and I had some issues about this that I will try to show up in my presentation. So the contents I will try, these are the 6 points that I was given by the organizing committee to cover during this talk. I hope that I will be able to, at least some of them, elaborate on and try to review the best out of it. Ethics and ethical principles and considerations in research. Why do research ethics matter? Types of ethical issues. Ratings, how you get your ethical approval for your proposal. The good ethical practice, and at the end I will try to give some examples of ethical failure which we should try our best to avoid. When we define what are the ethics in scientific research, it actually represent the moral principles that govern the conduct of researchers across the process of scientific research as regard to planning, implementation, analysis, interpretation, and publication. So we have to observe the ethical issues among all these steps and among the whole process of research. This is very important point, that all the process of research should observe the ethical background. If we go through the history of ethical principles in research, actually it goes back to the Greek days during Hippocrates and early days of medicine. And it is the same, actually, still the same principles that we should follow, that Hippocrates stressed on as regard to al-amana, al-muhafaza, adam al-kadhib, and observing the subjects, and so on. So these are the same things that has been going on through years and centuries. Alhamdulillah, in the early days, no ethical problems were faced, and even during the Islamic empires, as you know, our scientists during the Islamic empires did a lot of science. We did not observe, at least we did not have reported unethical behaviors in the early days. But as things gets on, as you know, مع ثورة العلم الجديد, we started to have problems. And probably you heard about the problems that were faced during War I and II in research and using human subjects. With these raised, a lot of efforts started, international efforts started to show up, trying to put a lot of rules and regulations on ethical designs during the research. The first trial was the Geneva Declaration, which was in 1974. And then we got the famous Helsinki Declaration, which was in 1964. And a lot of countries actually joined this. This Helsinki Declaration got a lot of revisions, and lately we started to have some problems even between the countries, and some countries did not actually sign the latest revisions. So even between countries, there are some issues about the ethical backgrounds that should be observed. The UNESCO effort, as you know, part of UN organization, now actually doing a lot of efforts and putting a lot of ethical rules and points through the research. The progress of the recent technology put a lot of pressure on this, and alhamdulillah, our country and our government, from the beginning, we realized that it is very important to put certain rules and regulations about the ethical behavior among researchers. And that's why, alhamdulillah, the establishment of اللجنة الوطنية للأخلاقيات الحيوية والطبية was early on in this country, and we are proud of this. It was established by our government. It belongs to مدينة الملك عبد العزيز للعلوم والتقنية. It was put under the umbrella of this organization. And actually, alhamdulillah, also College of Medicine and King Khalid put the first branch of this committee in Abha in the early 90s. And the committee, which was established in Asir region, was well known and actually was supervising research for years and years. Nowadays, alhamdulillah, we have more than one committee in Asir region under MOH and under the military hospital. And still we have our committee in the university under King Khalid University, which is now under the umbrella of the Deanship of Scientific Research. So this committee, which I will elaborate more about it when we speak about how we get your ethical approval. Why actually we should observe the ethical methods during research? What are the issues that we are looking at and why it is very important? First of all is as regard to the human subjects or even animal subjects that we are using in our research. These are subjects that we have to observe their rights, and we have to make sure that we are doing their best to protect them. And if we know the background of their rights, then we will be able to go through more and more protection during our process. The second issue is that sometimes the researchers, they would like to go into more deep results, and they may overlook the ethical background. And in these cases, it is very important to have supervision for the researcher during their process of research, so that they can they will be able to go through detailed ethical protections. Can I have some water, please? The other point about the ethics is are the individuals who are doing the ethical, who are doing the research. They should be individuals who are qualified, and they should be at the level of doing the research. And the ethical committees and the ethical supervision for research will look into these individuals, and we'll try to make sure that these individuals, they have capabilities to do proper research. Why research ethics matter? As regard to the country, there are some national and cultural issue of the country that should be observed. And the researchers who are doing research in the country should know this cultural background, and they should know the basis of the country, so that they don't override or touch these principles of the country. So our country should be observed during research. The environment, as you know, a lot of issues can destroy or pollute the environment. And unless we are careful and observing the ethical environmental protections, then we can run into trouble. So the researchers should observe the environment very carefully as regard to the ethical issues in this environment that he is doing the research with. The researcher also should be careful about the subjects that he is doing the research with, and he should be prepared that sometimes he may have to compensate the subjects that he is using, and this should go through ethical background first, so that we know how to handle our subjects and be careful with them as regard to handling the subjects of research. The risks and burdens should be also carefully looked at before the start of the study, and we should be careful to know how much harm we are doing, or always, of course, we are looking at no harm. But some research at some points may cause some degree of harm to the subjects, and the researcher should keep this in his or her mind. The researcher also should always look at the study as the study going on, because sometimes some research process should be stopped or modified. And unless we observe the ethical background, we might overlook and go on with the study. And that's why always we need some like supervisional committees to observe the study process. There are certain groups, as you know, that should have special care and special observation, and these groups are well protected and should be kept in mind always. So these are very important points about why we need to have our proposal go through the ethical process first before we start the study. And always we have to prepare the proposal and submit it to the committee for screening it deeply as regard to ethics. The committees always are available. All institutes now in the Kingdom, alhamdulillah, they have what we call as Institute Research Board, or what's ethical committee, research ethical committee, that are available. These are branch of the national committee that now running across the whole country in all institutes who are allowed to do research. These committees are available. For example, in our university, we have the ethical committee, we have the online submission, and you have to have the application. You have to fill up all the fields, required fields, and submit this proposal to the ethical committee before you start the study. Before you start. Unfortunately, I have seen some people doing some pilot studies. They start the study with few subjects before they submit for ethical approval, and this is a big violation of our ethical rules. Once you submit, then you have to wait. The PI, the principal investigator, will be the connecting person with the committee, and he should wait till the proposal being approved or declined. Once the proposal is approved, the study will be given a number, and the number will be a central national number that will be sent to Riyadh. So your study will be a national study with a registration number.
5 minutes.
So that's why it is very important to look at your study carefully, because it is a national study with a registration number. There are some studies where the committee may request a follow-up process during the approval. They will approve it, but they will tell you that after 1 week, 2 weeks, whatever period, you have to give us feedback about what happened. So you have to observe this if this has been requested from the committee. And even there are some studies where you may have to yourself, as a researcher, notify the committee if you notice any major changes, or if you had to change some of the method or funds of the research. So always you have to observe the issue as the research process is going on. These points are very important that you should observe as a researcher, and you should keep in your mind always during research process. The last part, I hope I can go through some issues about ethical failures, and we have to look into this. Sometimes we may overlook certain issues that we are not aware that this is actually a violation or a failure of the ethical process. Examples are a number of subjects. For example, if you have been approved for 40 or 100 subjects, you should not increase the numbers, even for animals. If you have been approved for 100 mouse, for example, or mice to be used, you should not increase the numbers. If you did, then this is a violation. If you change the site of the research process, this is a violation. If you add new funds from new process that the ethical committee is not aware of, this is a violation of the ethical process. If you also add false members of the study, adding that these members participated and they did not, it is really a bad failure of the ethical process that we should observe. Unfortunately, even the process, as I told you, of results and data interpretation can be and sometimes looked at in a different way that might not fulfill the ethical process, and we should always observe this. For example, adding more subjects that they were not there in the study or after the period, changing negative results to positive results. Unfortunately, this behavior has been observed in some studies, and ignoring some important outcomes that you have noticed. You will try to ignore them, trying to have a better outcome. This is also bad. The analysis also during the process of analysis, and our statistician here, I'm sure they know this, that sometimes you can do modification of your analysis that might, they can look better and they can be looking better. But this is, if it is not true, is a failure of the ethical process. Also, if you add names to the members who were not participant in these issues, especially during publication, adding authors or ignoring some authors during the process of publication is also unethical in the publication process. So in conclusion, the history of research ethics is well known across the human being history, since as early as I told you in the Greek period. Always you have to observe the ethical principles and ethical considerations during the whole process of the research.
Time's up.
Especially during planning, implementation, analysis, and interpretation and publication of the study. These are the points that I could elaborate on during these 20 minutes, although actually there are more and more things to be added to this subject. So I hope that I gave you the main headlines about ethical background in research, and I hope it was useful. If you have any more points during discussion, we can elaborate. Thank you, Mr. Chairman, and sorry that I had
Thank
few
you very
more
much.
seconds.
Thank you very much for fantastic presentation, actually, Professor Badr. And kindly, can you come closer just for the discussion? And the floor is open for any questions or comments. تفضل. Yes. Where is the mic, please? Mic. Yes. Can you just stand up and just mention your name and Which college and
السلام عليكم.
university?
فواز القرني, medical student. My question to Dr. Abdullah Sabani. From what I understand, in cohort study, we observing the outcome. After we starting looking for exposure from the time we started. How can I make sure that this population does not have exposed to this factor before I start the study?
To make sure, when we started recruiting the sample or the populations of a cohort study, we first of all recruit them, and then we asked them who is exposing to the factor and who is not exposing to a specific factor, and then we can ask them and we can assess the time of exposure to this risk factor. For example, let us say smoking. Okay, this is an exposure. We will divide people in a sample into those who are smokers and those who are not smokers, and then we can ask them for how long have you been smoking, how many cigarettes you are smoking per day, etc. etc. So part of assessment of exposure, you can ask different questions and different measures to assess the degree and magnitude of exposures to a specific factors, and then you can, in your analysis later, see the correlation between, for example, the high dose of exposure with the severity of the disease later on, or not. So regarding exposure, you can measure it. You can measure it from the beginning, and you can ask even about the past, if they have been exposed for a long time or not, if they are now ex-smokers or non-smokers. I hope this has answered your question.
Thank you very much, Dr. Abdullah. Any other question? طيب. تفضل.
تركي سعد السرحاني, medical student. I have a question for Dr. Taha. In case report, is it important, or is it the main purpose of case report that the case we will study will be completely unique? And the other question is, how can I make my cross-sectional study much better and much preferable for in my proposal?
Yes, thank you very much. So regarding the first questions, for the case control study, usually we start with the disease itself, and that's why we prefer to use it for rare disease. Because if you start with the other cohort study, right, you're gonna start with the risk factors, as Dr. Abdullah mentioned. Let's say if someone is they are smoker, then we don't know if we're gonna spend 10-20 years if they're gonna develop the disease itself or not. And that's why usually we prefer the case control study in order to follow up any rare disease, because it's in our hand initially. From day one, we know those target population, they have the disease, so we can start looking for this disease in the country, even like worldwide, and based on your experiments. The second question is about cohort study, right? The second question is cohort study and how we improve the cohort study. Cross-sectional, yeah. So the cross-sectional study, if you go back to the hierarchy of evidence, it comes before even the case control and the cohort study. So that's give you a shed of light, like this kind of a study is gonna give you less evidence compared to the case control and cohort. So you always try to go for the experiments which is gonna give you more trustful information. So for the cross-sectional, initially you will figure out your targeted population, right? You will measure the outcome and the risk factor or exposure at the same times. So try to find the right population. If you're gonna search about, as I mentioned in my talk, obesity and depression, you just try to find the right place and the right time to figure out those target populations. So this is one way to improve your end result of the cross-sectional study. Try to minimize the bias. One of the main bias, it's confounders, which is the differences in age, some of the characteristics of the population. So try to minimize this by make sure you got all right information about the target population before start your experiment. Thank you very much.
Thank you, Dr. Taha. Any other questions?
My question for Dr. Badr, where is what is some
Excuse me,
cases where
can you mention your name? And stand up, please.
what is some cases where obtaining the ethical approval is difficult?
Bismillah. I think the more difficult is about the interventional studies, because the interventional studies, you are doing some intervention to your subjects and your group, and then these interventional studies are more difficult, and always when we are in the committee, we are more careful to approve interventional studies. Although sometimes even the observational studies might go into certain groups who are vulnerable or are careful and might also give us some difficulties. But generally speaking, if you want a quick answer, the interventional studies are usually more difficult to get them approved.
I think Prof. Abdullah have some questions.
Thank you very much for all the presenters. My question is about ethics. To Professor Badr Al-Ghamdi. To prohibit unethical events or attempts by our researchers, we do have ethical committee, ethical government bodies, and all these official committees. But for those who are professional unethically, they can get around the things and get research unethical passed and done, and we have seen it even from major centers in the world. My question to you is that now we are talking to our students and our future scientists, is that parallel to this establishment of committees and government bodies, is that we should implement this notion in their minds when they are medical students or health science students at the beginning of their life, because probably this is the best way to implement ethical values and principles in their early stage of their lives. Now, from your experience, do you think what we are giving the medical students to implement these values and principles nowadays in the medical schools is enough? We give them a subject called medical ethics, I'm not sure how many hours, and then most of them they pass it 100%, they got A+, and they pass. Do you think this is enough? What should we give our students in their early life to make sure when they graduate, they have a very good base of ethics that you can rely on and depend that hopefully they will be a safe scientist in the future?
Thank you, Prof. Abdullah, for a very important question, really very important. And this process actually starts from choosing the students who are getting into medical school. And you, as a former dean, you know how we are careful on choosing our students and make sure that we choose high caliber students who have good hearts. So the choosing process in the researchers is number one. And of course, you will put more and more teaching, but always, as you know, there is no enough teaching. More teaching is better. But we try our best, and we have, as you know, the course of ethics, and good part of it on how you do the research and so on. And al-amana we know is very important in all medical behavior, not only in research. So it is a very strong point. The last point was put by the government. Alhamdulillah, you probably heard about how the strong punishment. The punishment process should be also very strong. The last punishment that we heard about, it's not a punishment, it is something that something we should be always careful about. It is now about 3 million riyal violation fee if you have been discovered doing an unethical process during research. So it is the choosing the persons and the individuals, feed them with good ethical matters, and put a strong punishment process for the unethical behaviors. These are our very strong points, inshallah.
Thank you very much, Professor Badr, and thank you very much for all of you. We reached the end of this session, and we hope you enjoyed our session today. Thank you very much.
باسم نادي الطب والإبداع بجامعة الملك خالد نشكر أعضاء هيئة التدريس على ما قدموه. يتفضل رئيس الملتقى لتكريم الدكاترة الدكتور عايض الشاطي. الدكتور طه القحطاني. البروفيسور عبد الله السبعاني. البروفيسور بدر الغامدي. نبدأ الآن السيشن الثالث إن شاء الله.